glad to have you here. So basically, the way we were thinking about running this session is starting off with an activity that would involve a little bit of moving around. Is that okay? So we're gonna actually have people move around, but what you can do is if you need to sit for a while during the activity, we'll have some chairs around so you can sit while we're doing that, okay? And then we have some presentations for you, and then we just want to kind of get into discussion. Does that sound good? Okay, good. So as you can see here on the wall, we put up a spectrum for you. So we're gonna go through an activity where you actually position your body in relation to how you feel about some statements that we're going to read off. And then we're going to have a discussion about why folks are where they are, okay? So obviously neutral is kind of here in the middle of the room, and then just sort of place yourself where you are with respect to the statement, with that extreme over there being strongly disagree, extreme over here being strongly agree. Okay? Cool. Do you want to read this statement? Or the first statement?
Okay, so the first question. If a woman has been diagnosed with HIV, she should not have children. Do you strongly agree, neutral, disagree, or strongly disagree?
And we can read each statement twice.
You want me to read it twice?
Yeah, we read it one more time.
All right, so if a woman has been diagnosed with HIV, she should not have children. Okay.
So I think we see where the room is. There seems to be consensus on this. Can somebody tell us why you are where you are? Yes.
Yes, ma'am.
It's her right to have children. It's not she should. Reproductive, we're all human beings and everybody has a reproductive right. HIV positive women and HIV positive men have a right, actually, to have a child.
All right.
Seems like there's a lot of agreement. Are there any other perspectives on this?
I would also say, obviously, medically speaking, there is very little risk if people are in comprehensive care, but also that for many people that have been diagnosed with HIV, they feel like their agency and their level of choice has been taken away, and this is a huge choice that people make. And it's important for people to feel empowered to make a choice either way about agency and reproductive rights.
Yeah, thank you.
Y'all ready?
Anyone want to add anything else to that? Okay.
Yeah, I think this is not a formulated thought, but in my work with Hive, I've seen so many women and then couples, come from this place of, oh, I didn't even know that people who had HIV could have a baby. As a society, our people don't know that this is possible. When I tell people what I do, they're like, wait, people who are living with HIV can have babies? Yeah. Yeah. And we do it, and we do it well, and it's possible. And exactly what Anne said, women, regardless of their status, have a right to have a baby if they want to have a baby.
Yeah.
And I'm glad you brought up that nuance, Krishma, because it's awesome that everybody in this room is over here, but we all know there are a lot of folks outside this room who maybe would not be there because they don't have all the information that you all have. And so I think part of what we want to do is think about how we can help to unpack that in places where we are situated.
So, if a woman living with HIV is virally suppressed, condomless sex is a good option for conception. Do you strongly agree, neutral, disagree, or strongly disagree? And I will read it again. If a woman living with HIV is virally suppressed, condomless sex is a good option for conception.
There's a lot of unknown factors in that statement, like in terms of the partner and what the risk might be, and the woman's personal reproductive health. It just seems like a lot of unknown factors to make a solid determination.
What are some of those factors?
Well, it's like we're saying about what the partner's status is, if the partner, what their discussions have been around what their condom use before trying to get pregnant, and also just in terms of the woman's, reproductive health regardless of her HIV status. For some people, condomless sex is not sufficient to get pregnant. You know?
Yeah.
So there's just a lot of unknown factors about the individual, I think.
Great, thank you. Yeah.
I think I'd be a little like, one, I don't know the medical side of it, so that's kind of why I'm more towards neutral. But then also, like again, those like factors, like are they in a monogamous relationship, or like is there a risk of like an STI, you know, that kind of stuff. So which is why I'm here.
Great. Does anybody in this like neutral area have a different reason than those that have already been spoken? Okay. So let's hear from, where are you putting yourself?
And the disagree.
And why is that?
Just because I didn't know the status of the other partner.
And why would that make a difference from your perspective?
Because then that could affect her viral load, right? Or her health.
So if her partner is living with HIV as well. Okay, cool. Great. So let's hear from some of the folks on this side of the room. Why did you place yourself on this side? Yes.
Because if somebody is virally suppressed, then it's a next to zero chance that they'll pass HIV to their partner. I am not living with HIV, but my husband is, and we have a baby together, and we have condomless sex. We've been having it for 6 years. I am still negative, he's virally suppressed, so that's fine.
Yes.
To me, the goal of the statement was for her to get pregnant. So for conception, the condom has to come off. Right? Virally suppressed is ideal, but even if she wants to get pregnant and she's not virally suppressed, the condom still has to be off. So condomless sex is a great option for conception. First of all, virally suppressed is the ideal situation for the mom. Obviously, what's going on with the partner is part of it, but I was hearing the statement more about for conception. So when conception is the goal, condom is off, great information that there's viral suppression, but I was really focused on the sort of the back end of the sentence instead of really thinking about, yeah, there's a lot more things. I wouldn't give that as my one piece of counseling advice. Once you're virally suppressed, Alyssa, the condom comes off and you will get pregnant. There'll be more to it than that. But I think that there is this fear, and we project that fear to our clients about how there's all of these things that you need to do. Partner status needs to be known. Your status needs to be known. You need to be virally suppressed. You need to be ovulating. You need to be doing all these other bunches of things. Instead of getting pregnant is something that women have known how to do for years without any extra help. In terms of like
even we don't want to, right?
Right. We don't want to. So I do feel like kind of putting that power back is important.
Great, thank you. Other reasons why folks are on this side? Anything that hasn't been said already? All right. Okay. So there were just a couple of questions that came up, and I wanted to make sure they got addressed. So there was a question about like sort of the relationship between viral suppression and what that means for transmission. Are people feeling pretty clear about that now? So there's very good data at this point that shows both from the HBTN 052 study, which came out in 2011, and then a follow-up study that was done with a lot of men who have sex with men, because 052 was mostly heterosexual couples. In both of these studies, they found that the chance of transmission when the partner living with HIV was virally suppressed to a partner not living with HIV was almost zero. And in fact, in the partner study, the PI on it basically said, we believe the chance is like negligible. So this is assuming that there are no other, STIs going on with kind of open sores, dripping, bleeding. We don't know about, in that kind of circumstance, how that could affect transmission risk, but it still seems, there's no known case at this point in time, a linked transmission from a person who is virally suppressed to a person who is not living with HIV at this point. So the data on that is pretty clear, but I think there are lots of other nuances to the conversation, right, that you all have lifted up around sexual health, reproductive health, and how you might handle this as a provider.
You ready?
Yeah, do you want to add anything? Okay.
That was great. Women living with HIV should always disclose their status to their sexual partners. Women living with HIV should always disclose their status to their sexual partners.
Something I wouldn't want to be. Do we need to read it again, or everybody heard it?
Spaces for the camera.
It's like, oh.
Okay, so the strongly disagree crowd, why do you feel that?
Always is a really strong word. Honesty's nice, but you don't owe that necessarily to complete honesty to every sexual partner. And if what you're saying is true about viral suppression, yeah.
Always disclosing would just be opening the doors to so much IPV that it's just not something that I believe should always be disclosed.
Anybody else in the strongly disagree?
I mean, I think that it's really important that clients understand what the law is in their state in terms of having condomless sex and being known to be HIV positive. And I still feel that we need to empower individual women to be able to have those conversations with their partners. And if she's not ready, she's not ready. It might be a situation of violence. It might be a situation of something else. But I think that without having that conversation, we don't know. So those always shoulds kind of thing, I feel like we're human beings and it's gray.
Disagree, folks?
I moved this way a little bit just because I thought like, okay, well, what if I was the partner? And I mean, I would want to know, but also I'm an understanding person and would understand why they didn't tell me. But that's why I was like, oh, I would want to know. Even if I wasn't really at risk of getting it, it would still be nice to know. So that's why I moved this way a little bit.
Anybody else?
I'm on the strongly disagree side, but I'm going to say what I was going to say. I think there's so much in this system specifically at SFGH for our patients. Disclosure, there's so much involved in that, you know? It's like, well, once you disclose, this person has to know, and then that person has to know, and, you know, all of a sudden you know, your providers might treat you differently, you know, be it nurses, be it doctors, be it pharmacists, medical assistants, you know, social work. It's as soon as someone, I've seen it, you know, and it comes through in our chart reviews, it's like, oh, well, I don't want to tell this person I have, I'm sorry, we're talking about partners, I know, but surrounding the disclosure to partners, it makes it very challenging. Our system makes it really hard to make it an easy process.
Now they have to come in and get tested.
Yeah, yeah. So anyway, there's a lot of stigma associated with it.
And what about the folks kind of over here more in the middle? Anyone want to share any other perspectives?
Yeah. No, it's kind of similar to, yeah.
I guess I struggled with this one. I put myself in neutral because I agree. I have the thoughts that were all expressed here, and then I had a thought of like, I put myself having empathy for both parties, and then I felt that pushed me into the middle. And but the statement is very, I mean, it's intentionally kind of stark, right? We don't know all the rest, and then everything that everybody said was swimming around in my head, and so I couldn't. So I just stuck in the middle.
Yeah. I want to also appreciate that both in this activity and in this statement and the last one, we had some folks who were sort of like lone wolves on one side, and I want to just like appreciate you for like being there and like speaking your truth, because that's what we're here to listen to from each other, right?
Follow-up question.
Yeah. So we have a follow-up question for you all. So what if the woman is not virally suppressed? Does that change anything about where you would place yourself? So the woman's not virally suppressed. Should she always disclose her HIV status to her sexual partners? And so if you feel any differently, we would want to just encourage you to move your body to show us how that changes where you would place yourself.
I don't think we knew she was virally suppressed in the first.
Yeah. But now I'm giving you some more information. So I'm just checking to see if that changes anything. It seems like it does. Okay, our next statement for you. Clients and patients living with HIV should be informed that viral suppression is an effective prevention strategy. Is.
Can you repeat that?
Yeah, clients and patients should be informed that viral suppression is an effective prevention strategy. Okay. I think we're having mind meld on this one. So, somebody who hasn't spoken, tell me why you are on this side of the room. Has everybody spoken?
I guess it gives you a chance to live longer, right?
How so?
If you take your meds.
Uh-huh.
I'm thinking in that sense.
Yeah.
If you're aware of it, then it's beneficial for you to live longer.
Yeah. So it can be beneficial for both the person living with HIV and the partner.
Yes.
Yeah. Great. Thank you. Anybody want to add anything to that? And it's okay if you've already talked.
I would definitely want to add the caveat that there needs to be a bigger discussion about prevention, and it's not just viral suppression. But I think one of the panelists mentioned that a lot of people make decisions not just based on themselves, but based on their partners. And I know a lot of our clients, one of the things that really encourage them to initiate treatment and to be adherent is understanding that treatment can be prevention. And while, again, in this bigger discussion about what all prevention is, that's a really big motivator, and it can motivate them to keep their partner healthy or their partners healthy, and as well as their own health by being on medication and being in treatment.
I was just going to say, just to add to that, that it's empowering to just know like knowledge like that, and just to know like how you can take care of yourself and your body. So.
In the old days, we had one prevention method, and that was the condom.
The male condom, right?
The male condom. And so that was it. And that was the one thing that we were, and in many cases still are, pushing on all of our HIV clients as soon as they walk in the door. Get a big pocketbook full of condoms. Because that's the message that we're sending is you need to do prevention, like starting when you go home today. And I think that this can be a very empowering statement. Viral suppression, so just, your ability to take your meds if you can is also another thing that's like in your personal prevention toolbox. And that's something that you have more control over, because condoms are not something that especially women have a lot of control over, especially male condoms.
Yeah. Yeah, thank you. And let me ask you all, to what extent do you think folks in the places you work, in your programs, and like people at kind of all different levels of service delivery, right, from medical providers to social workers, case managers, are giving clients this information? Like, what's your sense? yeah, maybe put yourself, like, okay, so the statement is providers in my setting are consistently giving this information to our patients and clients. So I see at least one strongly disagree. Why do you think that's happening? Well, what's your experience of what's happening and why?
I think that the staff from where I work is uncomfortable with the conversation, and therefore we don't ask our clients. We're a family resource center, so it's not necessarily like required. It's not on our intake form. It's not part of our like everyday case management that we have. But I know that there are clients that walk through our doors that don't disclose, and I just wonder like how much more we could be doing for those people if they felt comfortable disclosing, if we we're asking questions in a, with a trauma-informed lens.
Especially around infant feeding, too.
Especially around infant feeding. So I think that it's mostly not happening because our staff doesn't feel comfortable having the conversation.
Thank you. Okay, I see some people. Yeah, go ahead.
I'm in neutral because I think, well, first, I think that we just didn't know that that was true until a few weeks ago when Hive came to present to us, and we were all like, oh. And so now I'm hoping that at least amongst the counselors and the nurses that were there for that presentation, we will be consistently giving this updated information. And these are kinds of conversations that we are comfortable having because we talk about birth control all the time, and negotiating different options in terms of protecting yourself during having sex, condoms versus pills versus everything else. So I'm hoping that now we'll be moving towards the always framework.
Thank you. Yeah. Anne, did you have your hand up? No. Sorry, I thought I saw a hand up there.
No, I can speak. I think that we have 6 specialty centers that are doing a really good job, and we have 60 hospitals in Chicago. So the challenge is that it depends on where you go.
Yeah.
And whether or not you can actually really get connected with somebody who's going to give you good information that is reliable and connect you with this amazing group of people that really want to support you. But some people take a crazy long amount of time to get connected to us. And other people only get connected to us when the baby is positive, which is crazy. Oh, I guess now we need all the safety net services. So I think that there's a lot of stuff that's, for me, in the strongly agree category with that statement, but that there's enough others where it's just random. I train, I go back and I train, and I train, and I train, and I train. And it's just like, I'm hoping that it gets better.
And I can't help but think, I mean, I don't know about this particular thing, but just the way the controversies come up, I can't imagine there's a lot of people thinking if I tell my patient this information, they're going to go out and be totally irresponsible. So, I mean, I would think, how could you not tell your patients about that? That would be, so liberating. But I'm sure there's a lot of people that are hesitant.
Because we stereotype people.
Yeah, because, you can just go out and start. So. Yeah, exactly.
Yeah, I think that's right. I mean, we definitely have found, we've done a couple of community-based surveys over the last few years to just see how well this information is sort of penetrating into the community. So we did one in 2013, so like 2 years after the 052 data came out, and then one in the summer of 2015 after the partner study and 052 had been out for several years. And in the one we did in 2015, we found that, so we surveyed 181 women living with HIV in 7 different geographic parts of the country, and we found that they were all engaged in care regularly. Most of them are getting like lots of services. They're accessing lots of services. 40% of them told us that no provider had ever talked to them about viral suppression as an effective prevention strategy. And I think that there are definitely differences in sort of like geographically and like where you go for services, how well people are talking about this, but I think that a lot of the issues that you all have raised are very much a part of that. So from people not understanding the science to provider stigma around sexuality of people living with HIV, period, to like folks just being uncomfortable talking about sex, period, right? And then this sort of like paternalistic approach to clients or people living with HIV as if like we can't make responsible decisions about our own sex lives or informed decisions about our own sex lives based on information. So thank you for raising all that. I think it's really important.
And I just wanted to add, I did a listening session on Friday with Black women in New Orleans. And one of the questions was around viral suppression, and they didn't even know what it was. And this was a Part D program. And I couldn't say anything while the tape was rolling, but as soon as that recorder went off, I like jumped into the conversation with the women, and I was like, why don't you know this? And they said, no one has told us. No one is talking about this.
So, and you know, we don't know, like from the data, whether there are sort of like gender differences in how this information is being taken up, but it seems like very possible that there are, because women living with HIV are disproportionately women of color, disproportionately low income, tend to have less access to technology and science information, especially if they're in like parts of the country that are kind of outside of major metropolitan areas. So, yeah. We suspect that the picture is probably worse for women than it is for men overall. Do you want to do this one? Okay.
If a woman with HIV hasn't disclosed her status to her male partner and is having a baby with him, it is the provider's responsibility to make sure she tells him. I will read that again. I know I have this New Orleans accent. If a woman with HIV hasn't disclosed her status to her male partner and is having a baby with him, it is the provider's responsibility to make sure she tells him. Does everybody strongly disagree, or do we have somebody in disagree?
No. Disagree.
No. Strongly disagree.
I'm going to take the disagree first.
I would just to make sure she tells him, I would say to have a conversation about disclosure, but I wouldn't say the provider, it's a mandate that the provider makes sure that that conversation is had because of all the questions about safety that we just mentioned.
That was the hole I went down to, just thinking there's a role.
Yeah.
It's not, I didn't just want to throw it all the way out. Yeah.
There's usually something in the law about disclosure to partners. I know, and I can only speak to our own law, and it is that the provider, the physician, is the only one who is allowed, and by Illinois law, they're only allowed to tell the partner when they have made a reasonable attempt to support and encourage the mom to actually tell the partner, the baby's father, about her status. And even then, they're not compelled to tell. They may tell, but they have to document that they made a reasonable effort to try to coach and support her to be able to disclose that status if that's something that they felt they needed to do. They also don't have to do anything.
And do you find that providers are taking advantage of that law?
Taking advantage of the law in order to not say anything or to say something?
I mean, it sounds like the law allows them to tell, where everyone else is prohibited from disclosing, right?
The law is giving,
that information is
the law does allow only physicians to do that. We don't see a lot of that.
Is that the case in California? Do you know?
I don't know. Actually, I wasn't aware that. I wasn't aware that. As far as I know, there have been a couple of instances where medical providers have disclosed status in the last like 10 years or so to, we heard of one instance at Highland a number of years ago where a woman with HIV had a baby, hadn't disclosed to her partner, and they basically refused to let her hold the baby until she disclosed. It was really horrible. Really horrible, but and it clearly wasn't illegal because there was no suit brought, but there was an intervention done on the clinic.
I know that in California, if the parent asks why, because after a baby is born, they usually put him on like antiretrovirals for like 2 months, I think it is. And if the father or the partner asks why they're taking that medicine, they do have to disclose that because they're legal guardian. So there's that sort of like.
It can be documented in the record if she lists that guy as the baby's father on the birth certificate. If he's not on the birth certificate, then he doesn't have a right to know baby's HIV exposure status.
Yeah, as long as he's like a legal guardian, though, he does have the right to know. Or what
medicine they have to tell him.
What medicine the child is taking, and then from that he could gather that it's antiretroviral.
And do you know, in that situation, who is authorized to make that disclosure to him?
I don't know.
That's a little different. Parental law is different than what a provider can disclose.
Yeah. Yeah. Do you want to add anything?
I was just going to say, because, I'm down south in Louisiana, and we have crazy laws. But one that everyone seems to respect is partner notification. So what they'll do is they'll convince the mom or talk to the mom and say, we can notify your partner and we'll never say your name. Because we don't even want, we just want your partner to get tested. We don't want your partner to kill you.
Yeah.
So they'll do it like that. But if a woman has a baby, when I had my daughter, no one said anything in the delivery room about about HIV, even though my children's father was there and he knew. They didn't open their mouth. But
That's the way it's supposed to be.
Yeah. They'll go to the Department of Public Health will go to his house and say, someone someone who has living with HIV listed you as a sexual partner
in the last 10 years.
yes.
Yeah. And so one of the challenges we see, though, is that there are a number of folks providing frontline services who aren't necessarily really aware of some of these nuances and sometimes push people towards disclosure. So I'm sure you all have seen that as well. Okay, maybe we do one more.
Yeah. Okay. If someone is living with HIV, they should be charged with a crime if they transmit to their partner. If someone is living with HIV, all righty then. Anybody?
You can't prove it. How are you going to prove that my virus infected you?
You can. I mean, you could do the phenotype.
And just because we have the same phenotype, I mean, it's not the same as polio virus where you can really trace cases and we went from country to country to country. So,
yeah. That doesn't exist for other diseases. Like, people can die if they get the flu, but if you go to work or go to school and somebody gets the flu from you, there's no criminal prosecution for that.
Give Shannon a cold because we share an office, obviously it's very different, but we wouldn't ask that question about the cold or the flu.
Yeah.
Why do we have to ask this question about HIV? Like, why?
The only reason you need to think of it.
Yeah.
And criminalization discourages people from getting treatment and disclosing their status and getting tested in the first place.
So we talked a little bit earlier about the National HIV/AIDS strategy, and one of the sort of things I wanted to let you all know is that there is a national movement towards decriminalizing HIV. So yes, there are laws on the books in a number of states. I'll talk a little bit more about that later, but there's a large movement sort of towards decriminalizing HIV and recognizing these laws are very outdated, they're based on outdated science, they're based on kind of stigma and hysteria. And so even in the National HIV/AIDS strategy, both in 2010 and in 2015, there was a specific recommendation around state legislatures reviewing HIV-specific criminal statutes. And why does this have to happen at the state level? Well, because these laws are all at the state level. At this time, and so the federal government can't really directly intervene to roll these laws back. They have to be addressed state by state. And so, but what the federal government can do is things like putting out best practices, putting out guidance, calling for a review. The DOJ did a review of the laws across the country and released sort of a toolkit around that in the Department of Justice a couple of years ago. And so HIV criminalization, really is the use of HIV-specific and general criminal laws to specifically target people living with HIV. And in the conversation that we just had, I think we can all see why those might be problematic around sexual rights, reproductive rights, and just being a person, right? Living with HIV or wanting to get tested for HIV, as I think somebody brought up as well. And so we talked a little bit about this earlier as well, but there are obviously many different ways in which criminalization impacts communities. And so when we look at the social location of folks who are likely to be living with HIV, we see that there are lots of different ways they might be criminalized independently of HIV status, right? So criminalized around substance use, here in San Francisco, mental health, living on the street is criminalized. Sex work has been criminalized in many places across the country. The use of condoms as evidence of sex work is a huge problem. We're in this era where not only are we seeing kind of all different manifestations of racism, but also extreme xenophobia, kind of just very much in the national discourse, and kind of a huge anti-immigrant sentiment happening across the country that is very much linked to criminalization and deportation. Actually, one of the places that I personally think that the National HIV/AIDS strategy that was recently released is weakest is around immigrants. The only place in the strategy immigrants are addressed is in the context of detention facilities, where the strategy calls for testing. And can you imagine a place where people would be more vulnerable than in a detention facility? It's extremely problematic. And so when we look at vulnerabilities around how people might be targeted, penalized, deported potentially, and criminalized in any kind of sense, we really have to look at where folks are vulnerable and how all these different places and social locations kind of intersect. And so PWN USA has been working on HIV criminalization sort of as one of our priorities for a number of years, as one of our top priorities, and we have worked on it, we've taken it on as like one of our 6-part policy agenda priorities at a national level since 2010. And part of the reason for that is because women have often been used as sort of justification for these laws, right? So historically, these laws were many times sort of constructed using rhetoric around protecting women from their partners, and actually have continued to be proposed. So even just a few years ago, there was a state senator in New Jersey who proposed a new law, a new criminalization law, because he said, you know, the rates among Black women are unacceptably high, and we really need to protect Black women from their partners. So just sort of this rhetoric that really kind of places women as victims and kind of mobilizes homophobic discourses to perpetuate criminalization. And so we feel like it's critical for women with HIV to be involved in sort of rebutting those discourses and challenging these narratives and indirectly challenging these laws. And so also we know that women are in different ways kind of uniquely impacted by criminalization, have potential to be, both in the US and kind of around the world. So women are often tested for HIV before their partners. We heard earlier this morning on the panel that I think all of us had been tested in relation to our reproductive health, and it just so happened to be that way, but that's very common throughout the world, that women come into contact with the healthcare system more frequently than men. And so in a heterosexual relationship, the female partner is more likely to know her HIV status, usually, or is likely to know it earlier than the male partner. And then certainly, you know, trans women can be impacted in all kinds of ways by criminalization laws and are already impacted by the criminal justice system, as I talked about earlier, but can also be criminalized around things like sex work. So here in California, for example, we have a felony sentence enhancement if you are perceived to be soliciting, picked up for soliciting, and also know your HIV status and it's positive. So these, of course, these kind of laws also have huge implications for sexual and reproductive rights of anybody, of any kind of gender or gender identity. So it's around sexual behavior, getting pregnant, pregnancy management, how treatment could, they open the door to kind of coercion around treatment as well, which is potentially problematic. And as we're seeing sort of an assault and attack on women's reproductive rights across the country really increasing, including cases of women being charged with fetal neglect and feticide for a range of things, including substance use. You know, this is very scary to think that that women could be in this situation around HIV as well. So, yes, sorry.
In El Salvador, a woman was talking to me about how she was forced sterilization right after having her baby.
Yeah. Thank you for raising that. And that's a huge thing that we see. Do you want to talk about that at all? Well, I mean, I can just say a little bit, and maybe you can add. But definitely one of the things that we've seen here is we've heard a couple of instances of that recently among women living with HIV among our members. Like one in South Carolina who was sterilized just a couple of years ago following a birth. And is now has filed a lawsuit against the hospital that's kind of underway right now. But even more than that, we kind of hear a lot of stories of women who were coerced to go through tubal ligations and now have like very high levels of regret around that. And I think that's well documented in the literature too, that a lot of women who went through sterilization or were kind of coerced around sterilization, especially in the 90s, have very high levels of regret and are still living with that now.
And I know after Hurricane Katrina, I worked in Dallas, Texas for 2 years. And one thing we saw a lot there was young women were prescribed ART or medicines that you should not take if you want to get pregnant or if you're pregnant. So the doctor was prescribing this medicine to keep them from becoming pregnant, talking to, like, oh, you can't get pregnant on this medicine. But they had different options, but they were only prescribing that one to young women. Wow. And that's another form of coercion and, taking away your reproductive rights.
Yeah. Thank you for raising that. I hadn't even heard that before. Wow. So just a little bit about the landscape of HIV criminalization in the U.S. So as of a few years ago, there had been 67 HIV criminalization laws identified in 33 states across the country. Of these, 25 out of those 33 states had laws that criminalized one or more behaviors that pose a low or negligible chance of HIV transmission. So many of these laws don't take into account measures that reduce the risk of transmission, including, adherence to treatment. They were written way before we had any of that science. So they don't take into account treatment adherence. They don't take into account engagement in care. A lot of times they don't even take into account use of condoms or put the burden of proof on the partner who's living with HIV, disclosure, condom use, and things like that. And nearly 2/3 of these laws criminalize potential HIV exposure. So in many of these cases, and if you look at a lot of the prosecutions that have happened, transmission never even had to occur. People are doing sentences and doing times for things like spitting and biting in many states. And there was one case in Michigan where under a post-9/11 bioterrorism statute, a guy was charged on a bioterrorism charge who got into a fight with his neighbor, bit his neighbor during that fight, and was prosecuted under a Michigan bioterrorism statute because his saliva was considered a deadly weapon. So these laws are, obviously really, really problematic and not kind of, and they're really blunt instruments that attempt to deal with issues around disclosure, exposure, and other things. And so, I'm sure a lot of folks have kind of seen this power and control wheel. How many people have seen this before? So I don't want to take a lot of time to talk about it, but can someone just talk about what the power and control wheel is?
It has to do with interpartner violence, and these are just kind of listing the different ways that somebody can maintain power and control in a relationship.
Yeah, totally. And so, this is used a lot in intimate partner violence kind of communities to look at different forms of coercion and control, because like violence doesn't always look like somebody's hitting you, right? It can look like lots of different things. These are some of the different ways that it can play out for women. So using coercion and threats, intimidation tactics, emotional abuse, isolation, minimizing, denying, blaming, using children as like a bargaining chip, or threats around children, safety to children, custody of children, and economic abuse. A lot of different things can come up. And so we've been kind of looking at this as it particularly relates to women living with HIV. And some of the we did a survey a few years ago looking at sexual and reproductive rights for women with HIV, and this is just these are little quotes with some of the qualitative data we gathered. So one of our respondents said, I felt ashamed of my body and worthless. My ex would tell me that nobody else would ever want me because of my HIV. So, you know, this might seem really obvious, I think, to a lot of people, but to really understand the depth to which women living with HIV and people living with HIV can have, can be vulnerable to coercion, control, and abuse in relationships as a result of feeling internalized stigma and shame about their HIV status is pretty deep. And so there's not actually that much data that looks at the impact of an HIV diagnosis on trauma and violence within relationships or on different forms of abuse. The data that does exist is kind of a little bit outdated at this point. But it seems like, you know, it seems like definitely being diagnosed with HIV opens the door for all different forms of coercion and violence. Here's another one that I think you can directly sort of see how it relates to healthcare access. My partner didn't want anyone else to know about my status. He didn't even allow me to see my doctor because he was afraid of people finding out. So I basically had no support and wasn't getting care. So this is a partner who was worried about this. Her partner was not living with HIV, or well, I think actually he hadn't been tested, and didn't want anybody else to know that you know, the woman he was living with was HIV positive, and so was like forbidding her to access care because of his own concerns about disclosure. Here's another one. I dated a guy who knew my status, but when his family found out, he acted like he didn't know and brought charges against me. I almost lost everything. It has taken me a long time to disclose to anybody since. So this is a case where the guy actually tried to use criminalization laws. I think the charges have actually got dropped in her case, but he tried, and she ended up entangled with the legal system, and we all know that that can result in loss of a lot of different things for folks, from economic security to, you know, jobs to custody and a number of other things. This is another one where a woman said, I was in an abusive relationship for 4 years. When I attempted to leave, he threatened to come after me under these criminalization laws because I didn't disclose to him when we first got involved. And he also threatened to have my kids taken away. So here we see an instance where just the threat of using these laws prevented her from leaving the relationship for a long time. And, you know, and particularly, and this threat around like losing custody of her kids, having her kids used in that custody battle. Gina, do you want to add anything on any of this?
No, my partner, he didn't want me to go to the doctor because he didn't want. New Orleans is really small. A lot of people think it's a big city, but it's not. Everybody knows everybody. And we had one HIV outpatient clinic at that time. And he didn't want me to go because if people saw me there, then they would think he had it too. But he wouldn't get tested. He wouldn't get tested, you know, but it was on me. So I always felt like the bad person in a relationship, and that's how he was able to have so much power and control over me. And then he used all of those things in this power and control wheel, you know, against me. So, and I see it often with the women that I work with, and even some of the men that I've had the privilege of working with in New Orleans.
Yeah, I don't think anybody in this room is like, doesn't know this, but you know, our country has basically been set up in such a way that our healthcare system for many years has been predicated on employment, access to employment, and has been kind of set up to really disenfranchise people with chronic health conditions until very recently with the Affordable Care Act. And so for people with HIV, particularly those who were diagnosed, you know, several years ago or more, a lot of folks have been kind of pushed into permanent poverty as a result of HIV status because they're forced to be poor in order to access essential life-saving medication, housing, services that they need. And so we basically have created this, you know, biological underclass of people living with HIV, many of whom, as I think Eddie said earlier, want to go back to work, but don't necessarily have pathways out of poverty, or can't risk losing their disability status. And so, like, you know, even if they wanted to work, they can't afford to work because they might not make enough to sort of compensate for what they're getting from disability, or they can't take the risk that if they got sick and lost their access to disability, it could be a big problem. So, but We also know that a lot of women living with HIV are partnered with men who also don't have access to jobs and economic security. And so they're sharing their food bags, they're sharing their homes, they're sharing, and I'm sure a lot of you see this with your clients, right? Women are partnered with men who may have experience with the carceral state and like can't get jobs because of convictions on their records, or there just aren't economic opportunities available. And so even though there's all of this going on, the picture gets very complicated. Like the ties between economic insecurity and trauma and abuse and the access to that a woman might have to resources because she's living with HIV can actually complicate the relationship further, right? And make it harder for her to leave sometimes because she feels some kind of responsibility to him as well. So it's just very complicated. Then also, you know, I think we talked a little bit earlier about these, about like kind of how women see themselves in the world. I think that came up in the big room. But Michelle Tracy Berger is a researcher who's looked a lot at this concept of intersectional stigma, particularly among women of color living with HIV in the US. And motherhood and parenthood for women who are low income or women who have histories of interactions with the criminal justice system, histories of sex work, substance use, maybe don't have access to a lot of education, formal education privilege or jobs. For many women in those situations, motherhood and partnership can be the socially valued identities that are available to them, right? So like having kids, having a partner, constructing a family can be the thing that kind of gives you a certain level of social stature in your community. And so these intersections between like sexual and reproductive autonomy and parenthood and choice become really critical, and disclosure can get really complicated in that context too. So I am actually going to just quickly, like, I want to make sure folks know about the criminalization laws in California before I turn this over to Gina. So we do have criminalization laws right here at home. And most folks are from California, right? Yeah, cool. I just, but I thought it was just important to know what is actually on the books here, because a lot of people don't know this, including a lot of our clients. A lot of folks living with HIV don't know this. So we have 2 specific sections in our health and safety code. We have 3 sections in our penal code that all criminalize different aspects of exposure. And so we have, right now we have a felony on the books, HS 1621.5, which creates a felony for donation of blood, organs, tissue, semen, or breast milk by people living with HIV, which is out of compliance with federal law, actually, at this point in time. Mm-hmm. So there's an effort. We just got a bill introduced in the Senate last week, SB 1408, that is trying to undo this. We were only able to get it introduced for donation from people with HIV to people with HIV, but we feel like that's a good start. But basically this would open the door for things like organ donation from people living with HIV to people living with HIV. And research into that, which under the HOPE Act is already starting. We also have a felony exposure statute, which has a higher penalty than that for involuntary manslaughter or vehicular manslaughter. We have a felony sentence enhancement for solicitation while living with HIV. So if you are picked up for sex work, even for being perceived to be doing sex work, right? Because that's a lot of times what the solicitation charges look like. So you get picked up for solicitation. If it's documented that you already knew you were living with HIV, your sentence gets bumped up from a misdemeanor to a felony, and it's a 5-year enhancement for each charge. So this can impact a lot of folks. And then we have a couple of enhancements around sex offenses, and one for what's called infliction of great bodily injury, also related to sex offenses. So these are used, these I think have been used mostly in cases of sexual assault or molestation, and yeah, I think those are the primary ways in where those have been used. So there's a lot to undo right here in California,
and we have a lot of work ahead of us. But there are efforts underway, and if anybody's interested in being involved, there's a coalition, actually a statewide coalition that's working on this, and we have a Northern California branch that you can all come to meetings of if you want to. So how have these laws been used in California? The Williams Institute actually did a review of all of the cases that they were able to find from 1988 to 2014. And they found that 800 people in California had come into contact with the criminal justice system in relation to their HIV status over that period of time. 95% of these incidents impacted people either engaged or perceived to be engaged in sex work. And there were extreme racial and gender disparities in the application of the law that we were actually kind of surprised by. Because California, unlike a lot of the country, is mostly a male epidemic. Women are 13% of the epidemic here. And so we thought that, that we wouldn't see women heavily impacted by these laws, but we did, in fact. And so even though women are 13% of people living with HIV in California, we were 43% of those who came into contact with the criminal justice system as a result of these laws. And this data does not account for trans women, right, who are often, I think, misidentified by the criminal justice system. So we have no idea what the impact is on trans women. And then racial disparities. Black and Latino folks are just over 50% of California people living with HIV, but are 2/3 of those who came into contact with the criminal justice system in relation to HIV status. And so this report was released on World AIDS Day last year. I encourage you to take a look at it. The source is here in the slide deck. And I think these are going to be distributed afterwards. So I'm going to go ahead and stop and turn over to Gina, and then I think we can have some time for questions. Discussion.
So why people don't disclose, and I can tell you for me, it's all of those things. When I was first diagnosed, I came home and the first person I told was my mom. Only because she met me at the door and she said, "What's wrong?" And I'm like a baby. I just fell in her arms crying, and I told her what they said at the clinic. She said, "You need to tell your sisters." She didn't say, "Do you want to?" She said, "You need to." And I was like, I didn't mind telling my middle sister. It was my oldest sister I didn't want to tell because she's really judgmental. And I was like, I would rather die and go to hell before I tell this girl anything. But I sucked it up, and they came home, and I told both of my sisters my status. So the next person I had to tell was my children's father. I called him on the telephone because I am a woman who experienced intimate partner violence, and I was terrified of telling him. I just knew he was going to kill me. So I told him over the telephone, and he said, "I'm on my way." You know the story. I had my sister, my middle sister, who I love dearly, go on the porch and wait for him. And I said, "Let me know when he gets here." Because I figured he would come with the guns blazing, and he would shoot her first, and I would hear it, and then I could hide. Right. I told her this years later, and she was like, "You really did? I would never do anything for you again." But that was my fear. That was my fear. I had a fear of being alone. I didn't want to be alone. The stigma was really, really huge. I had more internal stigma than external stigma in the beginning. I wasn't worried about what other people thought about me. It was what I was thinking about myself. And then I knew that in New Orleans we did have criminalization laws, that people had been in the paper before, accused of transmitting HIV, and they put your picture and your name in there. And I was like, if I tell anybody, I'm going in the paper. Because if you remember from this morning, I'm also a recovering addict. And I don't know where my infection came from. I don't know where my virus came from. So I was afraid that if I went in the newspaper and someone saw that picture and that name, it might have been somebody that I traded sex for drugs or sex for money. And that's a whole nother thing. And also the violence. My children's father, when I was diagnosed, he stopped physically beating me, but it became psychological. He used my HIV as a weapon. So when he was killed in '97, I vowed that I wouldn't tell anybody else. As a matter of fact, I stayed out of relationships because I didn't want to have to disclose. Disclosure is a scary, scary thing. But what I've learned over the years, is if you have a desire to disclose, there are ways to do it. And I'm big on role playing. So the case managers in the room, y'all know what I'm talking about when I say that. You know, I will get with a client and we will play it out all day, every day if we have to. I used to work at our HIV outpatient clinic, and a young lady came in and she said, Miss Jean, I have a new boyfriend and I really want to tell him. What should I do? And I said, on your next visit, bring him with you. I said, I'm going to talk to the clinic, to the nurse at the clinic, and ask her to bring you in the room and pretend like we're giving you your diagnosis for the first time. He was in the waiting room. She goes in with the nurse. Not even 3 minutes later, I hear her scream. So the nurse runs out and get me. I run in. I mean, we should have won an Oscar for this. And he's sitting there, and I come back out, and he's looking terrified, and I said, you need to come with me. So he came with me, and we go in the room, and this young lady is on the floor. And she's like rolling around, screaming and crying. And he's like, what's wrong, babe, what's wrong? And she said, they say I have HIV. And he looked at me and he said, what should I do? And I said, well, you should get tested. That was in 2003. I left in 2005 because of Katrina, went back in 2007. I wasn't back at my old agency, not even a month, when I got a phone call. And the young lady said, Miss Gina, this is so-and-so, you remember me? And I said, of course I remember you. She said, guess what? I was like, what? You know, like, what? She said, you remember the guy I was with who you helped me disclose to? And I said, yeah. She said, we're married now. And I was like, but that doesn't work for everybody. You know, as Nana said, with criminalization, some people, even if you disclose your status to somebody, as we call it, mad gay, when they get mad with you, they can go and say you didn't tell them. You know, I also encouraged my clients when I was case manager to bring their partners to the appointment with them. You know, if you've already disclosed to your partner, bring him or her with you, and we'll talk about your HIV in front of them. And I will document it in your chart so that if anything happens, this chart is a legal document, and we can take it to court and prove that you did nothing wrong. You know, disclosure is really scary because a lot of times it's not just you. You know, I had children, and people can be cruel to your children, you know, and I may not fight if you hit me, but if you do one of my kids something, you will see the cat come out of me. I will scratch you up. You know, I don't care because my kids are my world. That's another thing that keeps people from disclosing. You know, their children, their communities. Communities are so full of myths and wrong misinformation. You know, I can remember once I was on the bus and these girls were talking about, yeah, this boy in the project got that gangster. And I just like broke out in a sweat. I was like, I think if I'd have been white, I'd have been red as a beet. I was so embarrassed, and they couldn't even see me, but I could hear them. But everything they were saying was wrong. Everything. They said nothing right. And I got off the bus and I was walking and I said, why didn't I say, y'all lying? That's not true. Because then I would be disclosing my own status, I thought, if I said something. I think with disclosure also comes not just the fear of physical violence or psychological violence, but the fear of death. Somebody could kill you, you know, and how do you get somebody to understand or talk to a person with HIV and get them to really be comfortable with, you know what, you can tell anybody and they can't do you anything. I can say that sitting on this side, but they're not going to believe me, you know. I remember when I told my daughter my status, she was 7, and I disclosed my status to her. And I only disclosed it to her because she asked, she said, why do you take all those pills and don't lie? And at the time, there was a book called Anissa Story, My Grandma Has AIDS. And we sat down, we read this book together, and I said, do you understand? And she said, I think I do. I said, Mommy has something like that, it's called HIV. And I didn't tell her it was a secret, I said it's private. And Mommy was asking you not to say anything to anybody, you know. And she didn't talk about it to anyone. She understood, but think about if she wouldn't have understood, and then she would have disclosed, and something would have happened to me, and that would have been guilt on her. You know, disclosure is a hard thing. It's not like you get your diagnosis and you just walk out into the world and be like, huh, I have HIV. You know, I have gotten to that point. I still don't just walk out in the street and be like, guess what, I got HIV. You know, I don't do that. But I'm okay if someone asks me, you know, hey, where are you from? And I might say, well, if your doctor gets Pos Magazine, maybe you saw me in Pos Magazine. And then they'll say, what is that? And I'll say, you have BET? And they'll say, yeah. I said, well, I had a commercial running on BET about HIV. And they'll say, why? I said, because I'm a woman living with HIV. You know, but like I said, it's easy for me now. It wasn't always easy. I can remember I lived in the neighborhood and the cab would come and get you. Back then. They made it so easy for you to get to your doctor's appointments. And the cab would come and pick you up and take you to the doctor. And this girl said to me one day, she was like, I saw you in the AIDS cab. And I said, no, you didn't. She said, oh yeah, I know that cab. I never thought to say, well, if you know, how do you know it? Yeah. I never thought to say that. The next appointment I had, I told my case manager, I'll catch the bus. I'll catch the bus. Because that was also a form of disclosure. For people to see you in something that was known as HIV anything. You know, you know, disclosure can be a scary thing. It can be a scary thing for all those reasons I said, but also because of that internal stigma that some of us carry. I'm not going to say we all, because I've had clients who was like, it ain't nothing. Okay, you know, like, all right, I respect you. You know, but the internal and external stigma can be huge. And that's the scary part to me. Also, just thinking that I could go to jail because I have a medical condition. You know, not that I've done anything wrong. I haven't robbed anybody, I haven't killed anybody, you know, I haven't raped anybody. I have a medical condition. And as you said, Sam, the person that I have sex with, I'm responsible for me, and he or she's responsible for themselves. You know, but we don't look at it like that. We look at it as if HIV positive people are predators, and everybody else are victims. You know, and that's not true. I would never put anybody at risk for anything, but at the same time, I know what it's like not to want to tell somebody. I can remember early in my diagnosis when I got over that my children's father was dead, and I got over the 2 minutes of I'll never have sex again. And I decided that it's too important not to. And I said, as long as I use a condom. And then I found out with criminalization, you can use a condom and still get charged. And I was like, this is crazy. This is crazy. You know, as a case manager, as a social worker, I never tell clients you need to tell someone. I never ever say, oh, you need to disclose your status. What I always do is I try to get them comfortable living with HIV themselves. You know, for a long time I couldn't look in the mirror and say I had HIV. I couldn't do it. And then my case manager, she was doing some role playing with me and exercises with me, and then I would go home at night when everybody was sleeping, I would get in the mirror and I would whisper, I have HIV. You know, like somebody in the house was gonna hear me or something, which they weren't. I think with disclosure also comes, you're giving a precious piece of yourself to someone else. And if things don't work out, that person could take that information and use it against you. And not just in the courts, but in the neighborhood, in your community, your job. I've had women tell me that their partners have threatened to call their jobs and say different things. One girl was working at a nursing home. Her boyfriend was like, you take care of those old people, you can give them HIV, you can give them AIDS. And she was like, how? I don't have sex with them. And he was like, if you don't do X, Y, and Z, I'm gonna call your job and tell them what you have. And because she wasn't open, you know, and hadn't disclosed her status on her job, she didn't want that to happen. had somebody else who was working at a fast food restaurant. Somebody from the clinic who was also living with HIV went there and saw that person and said, I don't want her making my food. She had AIDS. And the girl told me, she was like, if I'd had a gun, I probably would have committed suicide right then and there. It's a hard thing. And it's not like saying, oh, I have black shoes. You know, it's not like that. I think with disclosure, I think sometimes people who are not living with HIV feel like people with HIV should always disclose. I hear that from some of the case managers in New Orleans, and I ask them, I say, all right, if you had it, would you disclose? And then they give me that look. Because you know you wouldn't. It's a process. Disclosure is a process, and sometimes it takes people a long time to get there. And we have to meet people where they're at. You know, you want to add anything to disclosure? And that's about all I have, y'all.
I think we have a couple minutes for questions. Yeah.
Given this incredible information that you guys have imparted, I'm interested in your perspective on it. And I don't want this to take us too far afield, it's too off topic, but what is your opinion on the shift to opt out? Wait, am I right? Am I saying this right?
Opt-out testing.
Versus opt-in, right? We're moving toward universal testing without even, you know what I mean, an automatic. What do you think about that?
As someone who's a frontline worker, I encourage people to get tested, but I don't think that that it should be rolled into a lot of things without the information. A lot of times we're testing people and we're not counseling them. We're not giving them that information that they need, because what if your test results come back and you're negative? And I haven't really counseled you. We haven't really talked about a whole lot of things, because in 20 minutes, what can we talk about? You know, so it's, and some of the tests are even shorter than 20 minutes now. I was like kind of shocked at that. You know, so I think that it all depends on the jurisdiction and what the person is at. I don't believe in testing all, like they want to test all the prisoners. I don't believe in that, because a lot of the prisoners who would have to deal with disclosure, stigma, and all of those things in jail, it may not work for them. I think getting an HIV test should be a personal thing. It's a personal decision. And if you could get the counseling, if we could keep the counseling part in there, then I wouldn't have a problem with opt-out. But because we kind of took the counseling out of opt-out, yeah. That's just my personal.
Yeah, I'm interested in that. Thank you.
In my experience, one of the most valuable resources that can be available to folks who are in that space is just connecting with peers, like finding other people living with HIV that they can relate to. And so whether that's through a support group, if there are support groups available, sometimes there aren't, or sometimes people aren't comfortable with the support groups. I've had providers call me and just ask me about like meet their patients for coffee or something, and so for some of them we've like built a relationship through that, where they're not people who feel comfortable in a group setting. They have concerns about disclosure in that kind of setting, but it's really helpful for them to just have like somebody to bounce stuff off of and talk to. And so I mean, I think that there's trauma that comes from feeling betrayed, right? And feeling like somebody didn't disclose to you, and that's sometimes where the impetus around criminalization can come from. And so part of the work we're also doing now is around figuring out alternatives to criminalization, like restorative justice models and increasing access to mental health services and kinds of things that can help people work through that pain, because there is a like deep legitimate pain, around feeling betrayed about something and feeling like an injury was done. But what we found is that like a lot of folks, once they really kind of start to process through this and start to think about it differently, if they have the support and resources to do that.
And when you said about family, I forgot about that part of disclosure, when you disclose the family. I've had clients come to me and say, I wish I would have never told my sister. Every time I use the bathroom, she goes in there with the bleach. Or when I go to eat dinner by my mom, she gives me, my own little plastic everything. and everybody else is eating off the good china, but I have to eat off this. I had another girl who, her mom was a singer in New Orleans, and it was Thanksgiving, and they were, day before Thanksgiving, and they were all in the kitchen cooking, a family tradition, they do it every year. And she said her mom said, oh, don't let her get around the knives, because if she cut herself, we're going to all get it. Mm-hmm. And she was like, I felt so small. I felt like, you know, and that's trauma in itself right there. You know, that can really set a person back a whole lot by the way we're treated by our family and our friends, you know.
Yeah, and I think, I mean, the other thing that's just really important about disclosure and supporting clients, I think, is like making sure they also understand that disclosure is not a linear process. Like, it's never like, I mean, unless you're gonna, you know, just do a PSA or something, like, and even if you do a PSA, like, there are still gonna be people you encounter who haven't seen the PSA, right? So, disclosure is something that you are constantly negotiating, like, no matter how disclosed you are. And for me, personally, it was really important for me to be in a good place about my own, like, care and where I was with my HIV and my own, like, internalized stigma before I was ready to tell my parents, for example. Like, my sister knew, my friends knew, my partner knew, but my parents didn't know for like 6 years. So, because I needed to be in a certain place, because I knew they were gonna, I needed to be ready to support them, right? Like, and I wasn't in a place where I could support them for a long time around that. So, but even now, even as out as both of us are, like, there are still situations where it's like, should I disclose? Should I not disclose? Do they need to know? Like, what are the nuances around that? Yeah,
that's true.
It's always ongoing.